I'm so pleased today to start the third module, which is a little bit much more specialized than the other modules. And we're starting today. It is an honor to start the pediatric anesthesia tonight in the presence of three eminent speakers and two eminent and top moderators. We'll start with the microphone is going to Prof Samir Anaesthesiology. The first time since we started this course on Sunday, not to be a lecture, but he's honoring us today by his presence to be a moderator of this session with Professor Manal Elgohary. Prof Samir, all for you. Thank you.
Thank you, Professor. Good evening. Good evening, my dear colleagues. Good evening, my dear attendees. Really, today we are going to enjoy a pediatric night. Especially, we have three professional stars in pediatric anesthesia sharing us their experience in three hot topics in that field. And as you know, this field is unique in its critical. It is a critical branch which needs special attention and special experience and special talent because of its unique physiology, unique characters, unique special physiology, anatomy, and even in drug doses. We have to be oriented with its pharmacokinetic, pharmacodynamics, which differ largely from that used in adult. Pediatric anesthesia, as we know, carry special risk in morbidity and mortality more than, of course, the adult anesthesia. Today, really, I am going to be a moderator, and actually, I like to present, and I like presentations, and even I like to attend the presentation. But also, I like to be a moderator, especially if I am going to introduce such famous and professional speakers and guest speakers. Like today, we have actually three, as I said, three famous stars specialized in pediatric anesthesia, sharing us their long and extended experience in pediatric anesthesia. And please, my dear attendees, please help me now to welcome and introduce the prestigious and talent and professional, and also my dear colleague, Professor Dr. Hany Elzahaby, Chairman of Anesthesia and Intensive Care and Pain Management department at our dear and lovely university, Ain Shams Hospitals. Welcome, my dear colleague, Professor Dr. Hany. Mike with you now.
Thank you, Dr. Samir. It's my honor to be with you and my honor to hear these nice words about me. Thanks, Dr. Saad Mahdi, for letting me in this marvelous course, which is growing day by day. I'll start my talk today about basics of neonatal anesthesia, and I'll take the words of Dr. Anaesthesiology, who said that the great physiological and pharmacological differences or changes are there for these young patients, and they need continuous knowledge, continuous practice and skills added to an adequate monitoring and equipments to have a good outcome. We all know that the neonates are, we call them from day 0 to 29, whether full term when they reach 37 weeks or preterm when they are less than that. And the post-conceptual age is the gestational age add to it, the chronological age. Anesthetic considerations usually comes from being a neonate, and most of it comes from being a neonate. We call it age-specific considerations, and of course, the type of surgery. If we take system by system and see what happened in it and how does it affect our practice. We'll start with the CNS, and today we all know that neonates feel pain, and most of the pain components are there by 30 weeks of gestation, starting from the peripheral receptors down to the spinal cords, ascending tract, and cerebral modulation. However, the ascending pathway is not complete. Neurotransmitters are not there before 48 weeks of gestation. What does it mean that the descending pathway, the inhibitory pathway that modulates pain, that will result in greater intensity of pain for a longer time, hyperinnervation of the areas next to the injured tissues, secondary hyperalgesia, and of course, a 30%, at least 30% reduction in pain threshold with the next noxious stimulation. All these would have short-term consequences and long-term consequences on the nervous system of the neonate. They also have fragile cerebral blood vessels, which render them liable or prone for intraventricular hemorrhage in case of stress. Their spinal cord definitely extends at a lower level, and it's easy to get with that when doing a crude epidural. We come to it later in this talk. And of course, the volume of CSF per kg is higher, and the spinal surface area are larger in units. That means that when doing spinal anesthesia, we need more doses of local anesthetics. When it comes to the respiratory system, we all know that they have higher oxygen consumption, higher respiratory rate, the minute ventilation is higher. But when they are apneic, with this high oxygen consumption, so desaturation occurs more rapidly. Their lung compliance is less, and while their chest compliance is high. So by the end of apnea, they tend to get atelectasis. So whenever you intubate a neonate, the first thing is to recruit this segmental atelectasis that happens during apnea. Their diaphragm gets easily fatigued, and they cannot increase their work. So again, they get easily fatigued. Their breathing, which is we call it periodic breathing, normal periodic breathing of the neonate, is accentuated by the anesthetics, opioids, and make them render for post-operative apnea. We all know that the breathing circuit that most frequently used is the modified ISTPs. So let's see what will happen with this respiratory feature. We use the modified ISTPs because it's light, it's low resistance, no valves in it, the space is low, compression volume is low, gases goes in and out fast, compliance, the compliance of the circuit is low, and of course we can feel the compliance of the lungs and chest wall. However, we cannot add, most of the gases are dry, very low humidity, and it needs a learning curve to properly use it to the desired volume and pressure. And of course, it's difficult to scavenge. The bag may get obstructed and unused. So this is the other type of circuit that we use when controlling ventilation, which is a circuit system. Of course, this is a 15 millimeter diameter. When using these two circuits, we have to keep in mind two concepts: the head space concept, which of the circuit, for example, and the resistance of the circuit, which comes from hoses, valves, and filters. If the neonate breathes spontaneously in this circuit, the dead space may approach the tidal volume of the unit. You can imagine if we add to the spontaneous breathing one of these with a dead space of 34 up to 50 mils. So we cannot leave a unit breathing spontaneously in this circuit. And as a general rule, as we will see, that we cannot leave the unit breathing spontaneously for a long time because they get exhausted, especially when they are intubated and with a tube with high resistance, a lot of work of breathing. We cannot, if we add a filter to a spontaneous breathing, this is completely wrong. And even if they breathe spontaneously with through a laryngeal mask, although the resistance is low, but the dead space is high. Anatomically, they have a large ox. Of course, this is not an unit. This is a large ox. We have large ox which keep the head flexed always over the neck. So when you intubate them, you need a shoulder roll. You need this is the headrest and shoulder roll. That tries to align this trachea to the sternal end. Nasal turbinates are not there, so they breathe easily through the nose, and they suffer a lot when nasal obstruction. The floor of the mouth is compressible, so frequently if you press on the floor of the mouth from outside, then the obstruction of the oral airway occurs. The tongue is large and will again easily obstruct oral airway. And of course, we know that the larynx is high, and you have difficulty in aligning the visual axis of the three axes that we know. That's why in most of the case, we need external laryngeal manipulation to get a good view. The epiglottis is shaped, thin, and you cannot easily take it up, lift it up with the straight blades, which is commonly used in units. The vocal cords are slightly angled anteriorly. So most of the tubes come and hit the anterior wall of the larynx. So you need to tilt the tube to the left or decrease make a little bit of flex. Most of the, you have to examine the lateral view of the mandible to see if there is micrognathia is there, which is a very important and common indicator of difficult intubation of the trachea. Signs of airway obstructions, we all know that it includes a stridor, prolonged inspiration, some voice changes, crying is changes, rocking movement of the chest, abdomen, and of course, when they use accessory muscles, you get tracheal tug, flaring nostril, and retraction of the intercostals. They tend to get postoperative apnea in up to 44 weeks in term units and up to 60 weeks in preterm units. And the central and the apnea is commonly a mixed apnea, both central and obstructive type. Apnea, postoperative apnea is exacerbated by many factors, but we have anemia is the most important factor that predisposes to postoperative apnea. Other factors include hypothermia, hypoglycemia, hyperuricemia, narcotics, and we treated by raising the hematocrit, increasing oxygen, giving caffeine, maybe naloxone. But when we give this we don't send them home, and as they are safe, no, we keep on monitoring them for at least 12 hours of apnea-free period. When we come to the cardiovascular consideration related to the age, of course, they have high cardiac output, which is mainly dependent on heart rate. Their fetal hemoglobin has high affinity for oxygen. Their contractility is dependent on extracellular calcium. This is very important because if calcium is low, then it's difficult to to get normal blood pressure. Hypovolemia, or they have a predominant parasympathetic tone, so they don't get much tachycardia when they are light anesthesia, under light anesthesia or hypovolemic. Frequently, periods do not close if there is hypercarbia or hypoxia after birth, and which gives high pressure in the pulmonary artery, making a shunt, a right to left shunt from the pulmonary artery to the aorta. When the pulmonary vascular resistance goes down later on, then, and this is not closed, then the flow will be reversed. In patients with patent ductus arteriosus, using the right arm saturation is recommended. They lose heat by 4 ways. The most important is by radiation, which accounts to about 60%. Second is by convection. Okay, so it is important to keep the room temperature high, to wrap, to do cotton wraps around the limbs, and of course keeping air warming mattress, which is the most effective air warming way in OR. The renal function, we have less glomerular filtration rate. We cannot retain sodium from being excreted in urine, and of course when giving drugs they have a large extracellular fluid, and together with decreased renal excretion. So the initial dose may be increased for many drugs, but the intervals are usually longer. Their fluid requirements goes up through the first 5 days to be 150 mg/kg. And the electrolytes here, this is very important because frequently at the beginning of practicing pediatric anesthesia, many patients were cancelled for having potassium level of 6, and residents, junior residents, would think that this is high and needs some correction, but this is normal ratio for potassium. They also have higher levels of calcium, especially in the first day, and this is in day 28. So at 6.2 or 6.3, we go to surgery without any problem. Of course, we consider not giving succinate choline. When it comes to glucose homeostasis, we know the default is that all neonates need glucose infusion per kg per minute, about 5 to 8 milligrams per kg per minute. Their egoglycemic range is a range between 50 to 90. That means 40 should be treated, 110 should reduce the infusion rate of glucose. Of course, the lower limit is higher if the mother is diabetic and the neonate is the first 2 or 3 days. Hypoglycemia is common for if we are critically ill, if they fast for a long time. If you suddenly stop the TPM coming from the MSU. We have to know that most of the signs of hypoglycemia are blunted and non-specific, and we have to measure regularly the random blood sugar during operation. Is it then justified to use only glucose solution during operations? Of course not. We need to give the maintenance of glucose or half the maintenance of glucose because of stress, and then give the rest of the fluid as balanced salt solutions. We commonly have reflux, we commonly have pernicious. The hepatic drug metabolism is maybe affected, especially when the intra-abdominal pressure is high. The lowest acceptable hematocrit is higher than those of adults. If you accept like 25 or 30 in adults, the lowest acceptable hematocrit is 35. Their coagulation profile is almost nothing peculiar in it. So the fasting segregation, we all know that breast milk, 3 to 4 hours, we stop it. We keep giving clear fluids now up to 1 hour, and probably the as we say up to 0 hours. If they have clear fluid. They tell you they have clear fluid now. Then by the time they come, you just can induce anesthesia. In case of emergency and in case of full stomach, then you need to decompress the stomach in different positions. So you fix your nail with the tube, try to do gentle aspiration, supine, and then to the right side, then to the right side, then to the left side, and repeat the aspiration. Pre-medication is debatable. Atropine is maybe given. The lowest dose is 100 mics. Whatever the body weight of the neonate. Some people do not prefer to give. Of course, if there is pain, so the best pre-medication is morphine. Standard monitoring are added. ECG, stethoscope or pericardial stethoscope, blood pressure, temperature probes, whether lower esophageal or nasopharyngeal or rectal. Pulse oximeter definitely, but I have to elaborate that if you have a hypoxic unit, do not keep looking at the oxygen saturation because the pulse oximeter takes about 10 seconds to average the reading. So you have to look at the chest expansion. End-tidal carbon dioxide is crucial, definitely, but sometimes you get difficulty in getting good tracing of the end-tidal carbon dioxide, especially if you have a small endotracheal with a continuous leak around it. If the leak is large, then you will get that. This is definitely less than the actual end-tidal carbon dioxide. If you add P to this, then it will go down even more. So to get, this is a point where you measure end-tidal carbon dioxide. If you have this shape, then probably it's less than the normal, the real life. How long we pre-oxygenate neonates? That's since 1998. They said 60 seconds or 1 minute of 6 liters is enough to give you about like more than 1 minute of before they desaturate. Some people would prefer to get the end-tidal oxygen concentration above 80%, but believe me, it's difficult to achieve what you want. It's difficult to do real pre-oxygenation in units. And most of the time you need to do gentle manual ventilation to units before you intubate them, because otherwise you will get you try to intubate very early with the risk of regurgitation. Most of us will go for inhalation induction because even if I have a needle, if I have an IV in place, because they gradually get loose the airway, there is no pain from propofol. Definitely, if you have a short procedure, then they will be better than induction, and maybe the parental presence during induction will help in that. If you have IV access and they are hemodynamically stable, then you may go for propofol, or if they are unstable, you may go for ketamine. If there is no IV access or the airway is compromised and you want to go for sevoflurane inhalation, it's 6%. By the end of when they are deep, when their breathing slows and their end-tidal carbon dioxide starts to increase, that means they are in deep level now for intubation. Very common now to give a hybrid technique at this stage and give 40 milligrams per kg. Gives you apnea for intubation, but they cough later. Can we do a rapid sequence induction in units? But less classic rapid sequence induction that is in our mind for adults is not suitable for units because they easily get these hypoxic during the during apnea, and while they are not really deep enough. So again, you may get start early intubation, and which may predispose to regurgitation. So actually, there is no cricoid pressure in units in real life. You can do it because you will disturb everything. You cannot put your 2 fingers exactly at the cricoid pressure. Again, units must be gently, must be ventilated between induction and intubation. The gold standard is to intubate neonates whether for long procedure, intermediate time, or even for short procedure. Some would allow them for a very short, brief cases like circumcision to have a face mask with assisted breathing or a laryngeal mask in place. But remember that size 1 is commonly misplaced. And you frequently, if you keep on manually ventilating them, you may inflate the stomach. Succinylcholine, although the black box warning on the label is in the box itself, but if you need succinylcholine, if it is indicated for example, difficult intubation case, then you can give it without hesitation. Non-depolarizers, same dose as in adults, but we frequently give a single dose, like operation which stays for an hour, and we give the intubating dose, then probably we will not give another dose of non-steroids. Endotracheal intubation, gold standard, oral or nasal. Nasal if we are going to put the patient on prone position or even lateral position, or if you have a limited head access like in maxillofacial, then a nasal intubation may be a solution. The leak pressure should be less than 25, and in most of the cases we intubate with non-covered tubes because first of all it puts less pressure on the mucosa. You can put a larger tube, one size larger, but if you have poor lung compliance, then you may put a cuff tube. Frequently, we put the micro-cuff tube if you have it. If you don't have, then the other, the regular one will be okay, but you have to measure the cuff pressure and make sure that it's not tightly inflated. Gold standard again, after intubation, as we said, the atelectasis, commonly, segmental atelectasis commonly occur. So we need to recruit the lungs after intubation, immediately after intubation, and then to put them in feet that will prevent more atelectasis. This is a paraglossus technique, which you go from the far right side. You don't you go direct to the base, to the right side of the base of the tongue, directly to the epiglottis. Just take it with you, and you can intubate in this position. Here is these two types. This is a micro-cuff tube, which they replaced the Murphy eye with this, so that the tube, the cuff is more distal. That is more anatomical because here is the narrowest part, probably is here, which may give, when using this micro-cuff tube, then probably post-intubation group would be less. But the size should be, is frequently be one size less than if you are going to put 3.5 non-cuff, then with the micro-cuff, then you put size 3. Pressure volume control or manual, which is frequently used, definitely. If you want to use a circle system with them on controlled ventilation, then classic teaching is the pressure control is the first choice because it avoids the barotrauma and compensates for leaks. What happened is that we go for the PIP, the peak inspiratory pressure. We set the highest pressure that we want. For example, starting by 10 or 12. And check what is the expired volume. How this pressure with the current compliance of the chest wall and the lung and the surface, everything will give an expired, because if you are giving pressure control, you have to look for the volume. If you are going, in case if you are giving volume control, you have to look for the pressure. Then after checking this target, our tidal volume, usually we go for a protective lung strategy. The upper limit is like 6 mL. I personally go for 6 to start with, and then so I increase the pressure until I get 6 mL per kg. And then after that, I go up, I manipulate the respiratory rate to the desired endotidal carbon dioxide and add it. What factors that affect the tidal volume in pressure control. The compliance, and here we have to bear in mind that the hand surgeon, the surgeon's hand itself, will decrease the compliance, and if the assistant retracts vigorously, then you will probably get nothing, no tidal volume. So you have to keep watching the expired tidal volume yourself, or use a pressure control volume guaranteed. This is a very useful. The other two factors are the inspiratory pressure, which if you increase it, then you get more tidal volume, and the inspiratory time difference. What is the disadvantage of pressure control is if the tube is kinky, for example, it will not allow. Disadvantage of volume control that we occasionally may use in case of decreased lung compliance or anesthesiology or whatever. Then, because the disadvantage is that they do not compensate for leaks. And the phased flow, if you increase the phased flow, then the tidal volume increase goes up. If you decrease it, it will decrease. And of course, you lose volume through the circuit compliance. So if you adjust for example, if you put 50 mils, then you may lose 20 of them in the circuit. Of course, maintenance, I don't think anybody is using Halothane now. Occasionally, in some cases of difficult intubation, I still use Halothane for more time of laryngoscopy. Narcotics for fentanyl or morphine. The difference is, although morphine has longer duration that stay for like 8 or 9 hours, but the half-life of fentanyl is variable, extremely variable. It may be half an hour, maybe 7 or 8 hours. It depends on the high intra-abdominal pressure. So we usually avoid short procedures, and we revert to a regional block. Narcotics, again, they have low rate of clearance, high volume distribution, prolonged half-life. Their plasma concentration after bolus dose of narcotics is high. We can give narcotics easily to a patient who will be ventilated in the ICU, but we tend to stay away if we are planning to extubate and recover the patient. When it comes to regional blocks, the CSF volume per kg are higher. You see here it's almost 15 ml per kg. It's like 1.5 ml in adults. So this means that they, together with a leak around the spinal nerve, we have to give higher doses of glucoacids for spinal in neonates. Their turnover, CSF turnover rates are high, so the spinal will stay half an hour, 40 minutes maximum, unless you add it enough. Their globular fat is less dense, and you can easily thread a catheter caudally up to higher levels. So traditionally, we give spinal doses. You ask assistant to hold the neonate for you in a sitting position and use a separate needle. You just break the skin and by a separate needle to avoid inclusion dermoid, and then we give 0.1 ml per kg of bupivacaine